Homework. Everything else, okay? Okay, we'll get it.
We'll get it and then
We'll get it. And it'll never change for me as far as how I do it. I can't promise on this. And this is someone without a name. Well, good? Okay.
I wrote my own stuff at the top of like that. Coming from IM.
Okay, I have one question here. I have 3 spectral because on that last one, we were having that problem with CCA, and I found it, and they're all 3 showing up on mine.
Okay, what does it say in there?
That I just missed that image.
Okay, we'll look back at it. Alright. Let's see. Was it the long homework, 35 questions?
Mm-hmm.
Okay. Let's go over that real quick. First of all, we'll go over the answers to this quiz so you'll know pretty much what you made. Alright, the CCA branches into the I and the E. Okay. The vertebrals join to form the Vascular. The innominate is also called the brachiocephalic. The left subclavian comes directly off the aorta. The right comes off the innominate. Okay. The ICA is low resistance, feeding the brain, needs a lot of blood flow. ECA is high. First branch off the I is the ophthalmic. First branch off the E is the superior thyroid. Which artery is usually located lateral? That is the ICA. When you're looking, a lot of people miss that for some reason. But when you're looking at your image, they usually sit like that. Which one of those is lateral? ICA. Okay.
Yeah, I think it's just because all those questions said it says lateral to the ECA and one says lateral to the ICA.
Which a stroke resolves, it takes longer than 24 hours, it's a REN, and TIA is less than 24 hours. And causes of CVA, you could have put embolism, thrombus, hemorrhage, or ischemia. Any of those would work. And the which branches intracranially, that's the ICA. The branches inside the brain is where you can't see the branches. We're talking about that. The only time you can see them is if you're using transcranial Doppler. All right. And then the branches in order are the superior thyroid, ascending pharyngeal. I'm going to look at my order here. Superior, ascending, linguinal, occipital, facial, maxillary. Then you got posterior auricular, then maxillary, then superficial temporal. I have to write them down. But anyway, so that's the order of them. Yep. All right. So now we'll go to our homework. And I'll finish it now. If you miss the order of them, it doesn't count against you. If you got them, you get the 5. If you don't, whatever. Okay? All right, on your homework, number 1, a CVA is a completed brain stroke. 3 causes of a CVA, again, thrombus, embolism, hemorrhage, or we added ischemia in there. So any of those will work. What resolves within 24 hours? A TIA. The inability to speak or express yourself is aphasia. Vertigo is considered a vertebral basilar symptom. History of a patient during a carotid exam, you want to know if they've had any of those: hypertension, hyperlipidemia, any sort of vascular surgery, name them, what's some more? Diabetes, do they smoke? All those things. They're on page 26, I think. Okay? The CCA sits lateral to the thyroid. And then the CCA sits medial to the jugular vein. Does everyone understand that? So it's an image if we don't. Okay? The best window for the ICA is posterior lateral, and the best for the E is anterior lateral. The ICA lies lateral most of the time, and then the ECA is usually smaller than the I. An angle of 45 to 60 should be used. And 14 will be a linear probe. Most of the time it's 7.5, but you can have 9 or 12, but just no linear probe, okay? 15 would be a wishbone or a tuning fork. 16 is ECA. 17 is ICA. 18 is the temporal tap. 19 is more dangerous. Why is heterogeneous more dangerous? Because it can break off and form an embolism. Okay. And then, where are we at? 20 is residual lumen. 21 is 60%. 22 is, I just got a page number. To make it more image, turn up your color gain, decrease your color scale, make your color box smaller. Has anybody got anything different?
And color invert.
Okay. 23 is the same direction. 24 is low. 25 is 60%. 26 is the CCA. 27 is helical flow. 28 is your ECA. 29, they're low resistance, and they should have antegrade direction, which is based on top of the baseline. 30 is parallel. 31, 3, also 3 sites throughout the vessel, prop within and distal. 32, what can help diagnose an occlusion of an ICA? Use a smaller scale, use power Doppler. Anybody got anything else? Okay, we're going to move on. I've just got the page number 44. Okay, 33 is retrograde. We're going to talk about that today. We didn't get to that last week, so we're going to talk about that today. 34 is the carotid dissection. I believe we've touched on that. And 35 is an endorectomy or a stent. And today is Julissa and Brooke's day. For me to make a copy of y'all's homework. Thank you, madam. I'll give it back to y'all. Don't forget, I'll give it back to you. Okay. All right. All right, we're going, huh?
On the synopsis when you got what you said 5,
3. Do 3 areas around it, prop, within, and distal. Then you'll go for 3 within the actual stenosis. So it's actually 5 altogether, but 3 is prop within and distal. All right, we're going to go over chapter 3. I gave everyone one of these. You will get tested on this. So, like if I say a patient has a 50% stenosis, you need to know what their peak systolic velocity should be. Or if I give you a peak systolic velocity, you need to know what percentage of stenosis that is. Okay? Every site you go to is going to be a little bit different on what they figure is 50% stenosis, depending on velocity. This is just the one that we are supposed to be using in this program. So this is the one that you'll learn here. However, you go to a hospital, when you start doing clinicals, they're going to have something like this hanging up in their vascular lab, and the numbers may be a little different. But it just gives you an idea, like we talked about before, if you measure it in transverse and it's supposed to be 40%, or we'll use one that's supposed to be higher velocity, 60%, well, using this chart, you know that your peak systolic should be between 150 and 250, okay? It's kind of like a little cheat sheet for you to know. Or if you're getting velocities of 200, but in transverse, you're only getting a stenosis of 30%, you know that's not correlating together, so something's wrong, okay? So it is important to know this, and like I said, you'll have one hanging up in your site if you go to a vascular lab. All right, so that's pretty much what chapter 3 is talking about, but the first thing I want to go over is what I have drawn up here. Let me move this out of the way. I'm watching the other thing. All right. So first of all, where does the ICA provide blood flow to what? The brain. And the ECA provides blood flow to the face. Okay. So if you look at this image right here, we know that the CCA comes up, divides into the ECA and the ICA, and that's all the branches there I've drawn in the ECA. If the ICA is occluded, how in the world is blood going to get to the brain? The ICA is occluded. What'll happen is a couple of these branches is not for, it can be any or, so you don't have no specific, but about at least two or three of the ECA branches will connect to the ophthalmic branch of the ICA. The ophthalmic branch is the one we cannot see, but it's the first branch off the ICA. So, I guess I can just draw it up here. So let's say this is my ophthalmic branch coming off of my ICA. What will happen is a couple of these branches will just connect into that and it bypasses the occlusion. Okay? So during an ICA occlusion, ECA branches connect to the ophthalmic branch to get blood flow to the brain. So during an ICA occlusion, the ECA branches will connect to the ophthalmic branch and provide blood flow to the brain.
And that happens naturally.
Your body forms, it's called collaterals, and your body just automatically forms. It forms its own bypass graft.
It must be pretty quick.
Yeah, they form. Well, as the occlusion gets worse, the collaterals start to form, and they start to mature to be able to take over that blood flow. And it's your body's own bypass grafts. Now, are they going to last forever? No. Eventually, you're going to have to go in and get an actual bypass graft put in. Okay. I think we talked about how an ICA occlusion is more important because it's feeding the brain, and we need to know if it's occluded or if it's 99%, because they can have surgery, right? Once you get 100%, there's no way to have surgery, so they can't have an endorectomy done. And collaterals are not going to form until you get 100%. Well, they might start forming, but they're not going to start working until you get 100%. So once that happens, your body forms its own bypass graft, but over time you're going to actually have to go in and put a bypass graft in. Okay? So that's why it's important that we catch them before they get 100%, because the bypass graft is pretty invasive surgery, and it's not going to last forever either. So if we can catch it and have an endorectomy done or a stent, it's a better outcome for the patient. Okay? So during an ICA occlusion, ECA branches will connect to the ophthalmic. So let's say, these two branches, they're going to connect up here, and they're going to completely bypass that obstruction and carry blood flow from the ECA to the ophthalmic and provide it to the brain. Okay, so the brain's going to still get its blood flow. Is it going to get the normal amount? No, because the ECA is smaller, but it does get some, which helps the patient from developing a stroke. Okay. Now, because the ECA is now providing flow, these branches are providing flow to the ICA, this ECA takes over a low resistance pattern. The ICA is supposed to be high resistant. Okay? When an ICA is occluded, the ECA itself becomes low resistive. Alright? And I got some images I can show you. So when the ICA is occluded, ECA branches connect to the ophthalmic, but the ECA flow becomes low resistive. So when you're scanning as a tech and you're moving up from the CCA and you get to a vessel that has low resistive flow, what do you think it is? You're going to think it's the ICA, right? If you're up there scanning and all you can get is one vessel and it's low resistive, chances are the ICA is occluded and now the ECA is taking over that flow and it has become low resistive. Okay? So keep that in mind when you're scanning and you can only find one and it's low resistive, chances are the ICA has become occluded. Another thing that will help you with that is, hang on, let me pull this up real quick so I can show you the difference between low resistive and high resistive, because not everybody got to see this last week. I'm going to turn the light off for just 1 second to show y'all. Okay. Oh, it's not on. Okay, first time. Okay. Won't work lots of time. Is it green? There we go. Oh, it's the blind. Usually don't have that running through there. Anyhow, alright, so this is the ICA. It has a low resistive pattern. We talked about how it sits off the baseline. You'll see this, it never touches the baseline. It has a lot of diastolic flow, and the peaks are not very sharp. So that's a normal low resistive pattern. However, some of y'all's ICA doesn't look like this. It touches the baseline. It has the high peak, so you can't always depend on your waveform. But again, this is a normal low resistive waveform. Doesn't touch the baseline, a lot of diastolic flow, and the peaks are more rounded. Also, the velocity is only, 60, maybe 70, so it has a lower velocity. When you get to the ECA, see how it has a sharper peak? Still has a diastolic flow. See, this one doesn't touch the baseline either, and the ECA is supposed to touch the baseline, but it does have the sharp peaks that the E should have, and the velocities are about the same also. So one thing that'll help you mainly is just looking at the peaks. Does it have the sharp peaks, or does it have the more rounded peaks? Okay? So when you're scanning with an ICA occlusion, and you get up to a vessel, and it has that sort of pattern, you're thinking, well, this is the ICA, but you can't never find the ECA. Again, chances are the ICA is occluded, so the ECA is acting as the ICA, okay, providing blood flow to the brain. How does it do it? By branches that connect to the ophthalmic. But another clue for you, since your body makes its own bypass grafts, they will work for a short amount of time. They're not going to work forever. It could be years, it could be months. I mean, I don't know. There's not a certain time. If these branches are not working correctly, it affects your CCA flow. Okay? So if these branches, they're just not providing the blood flow that's needed to the brain, it'll start to affect the CCA flow. And the CCA flow will lose its diastolic component. So that's another way for you to know as you're scanning up. If your CCA loses, this part, the diastolic flow, that's also an issue, and that lets you know if there's something going on up the patient's neck, okay? So pay attention to the way the CCA flow looks, and then if you're scanning up here and all you can find is one branch that's low resistive, chances are it's probably the ICA. So your first clue would always usually start off with the CCA. You're like, this CCA flow doesn't look right, don't have diastolic flow. That should hit you right there. There's something going on up this patient's neck, probably an ICA occlusion. Then you get up to the ICA and E. All you can find is one vessel. There's your other hint. Now all I can find is one. It's low resistant, it must be the E. Right? So it's very important that we catch these occlusions, because again, the patient's going to have a bypass graft put in. Alright, so that's your first thing, ICA occlusion. Now you move on to an ECA occlusion. Alright? ECA occlusions are no big deal. Why are they no big deal? Because all those branches are going to feed the face. Okay? That's all you need to know about the ECA occlusion. No big deal. The branches, your CCA is still providing eye, brain's getting flow. ECA is occluded, so what? You got, 7, 8 branches that are going to carry flow to the face. So that's an easy one. They're not going to do nothing about it. Who cares? Okay? But this one is a little more important also. The CCA is occluded. Well, if the CCA is occluded, how is blood even getting to the E and the I? Right? Alright, here's what will happen. First off, the brain is the most important. So the ICA steals the blood flow from the ECA. So now your ECA flow is retrograde. It's below the baseline because it's backing up and it's feeding the eye. Okay? That's your first step. CCA is occluded, ICA steals from ECA, so now your ECA becomes retrograde. So it's staying below the baseline, it's backing up to feed the eye. The brain's more important than the face, despite what some people think. Okay? So, retrograde. So it's below the baseline because it's backing up and it's now feeding the ICA. Because that's your most important organ, your brain. You gotta get blood from there to keep everything else going. Alright, well, if ECA is backing up to feed ICA, what's feeding the face?
Those branches.
The branches. Good job. ECA is backing up to feed eye. So what's feeding the face now? The branches are feeding the face. But your big question should be, well, how in the world is blood even getting to the ECA to feed the ICA, right? Exactly. The vertebrals or the basalars will become retrograde and feed the ECA. So, CCA occlusion, first step, ECA becomes retrograde to feed eye. Okay. Branches feed face. How does blood get to the ECA? The basalars will reverse. And what does the basalars branch off of? The vertebrals. So the vertebrals will reverse, and they will provide flow to the ECA. Okay? So vertebral basalars become retrograde, and they're providing flow to the E, so E can get it to the eye, so I can get it to the brain. So if you do find a CCA occlusion, you have to be sure that you scan your vertebrals. And you should find flow below the baseline because they're backing up to feed the ECA so they can get blood flow to the eye. Okay? Also, ECA should be what? Retrograde because it's feeding the eye. Good job. All right, what type of flow do you find over here for the ECA? Low resistance, right? The branches are connecting to feed the ophthalmic, but the ECA now becomes low resistance. That's why this one is the trickiest one. Because you think this is the ICA, but it's not. It's the ECA. It just has low resistance flow. This one, who cares? Okay? This one, also important, and you have to check many things. You got to check ECA, you got to check vertebrals. You can't check basalars, but you know, you just check it all out. So that is how blood flow will still reach the brain. No matter what, it's going to get to the brain. Okay? What will happen though in this one right here, because blood is stealing from the basalars, what does the basalars go into? The back of the head. Now we're talking about the vertebral basilar symptoms. So in this case, this patient should be coming in with vertigo, syncope, drop text, all those symptoms. So when they come in with those symptoms, we find CCA occlusion. Well, we know why, because the vertebrals on the basalars are backing up. They're not feeding the brain anymore, the back of the brain. Now they're feeding the E. So they're going to come in with all those symptoms. Right? So everyone got the steps of what's going to happen.
Okay, can you go over the last one?
This one? All right, so your CCA is occluded. What will happen is the ECA will become retrograde to feed the eye. Got that? All right. The ECA branches will feed the face. So your brain's taken care of and your face is taken care of. But how's blood getting to the E? The vertebral basilar will also become retrograde to feed the E. And that's why the patient will come in with vertigo and syncope, because it's stealing blood flow from the back of the head, making them have those vertebral basilar symptoms. And one thing about this that makes it a little more tricky is you don't care what branches are feeding, but do you need to find those branches feeding? Yes. You need to be able to see those branches. And you can't always see all those branches on ultrasound, so they're going to order a CT or an MRI to get a better view of what those branches are doing. If we can't do it, but we know there's something going on, they'll send them for something else. All right. Got it, got it. Good, good. All right, then on chapter 3 is where we're gonna start. Page 72. What year are y'all supposed to graduate? Next year in December? I don't know if y'all heard or not, that January of 2017, in order to do any vascular scans, you have to be registered vascular. Big deal. Vascular is probably the hardest one to take. So, anytime y'all get lost, stop me. And then vascular 3 is nothing but register review, getting y'all ready to take the test. Okay, so I hope to have y'all there, because it is going to be very important that y'all get it. Yes.
What's the percentage of people who?
Vascular is our lowest right now. It's only about 40% that pass. OB's 80%. Physics is 100%. Everybody passes physics. Believe it or not, it's 100%.
I know, I
pass
feel like
rate.
I'm not there.
And then abdomen's about 50%. Yeah. But we haven't pushed vascular so much because it is the hardest one and the school pays for it. We're not going to take the easiest one, which is OB, and get registered. Now, that you have to be per month. Huh?
Do you pay more?
You're supposed to get paid more.
Since the laws, they
You're
come.
supposed to.
Yeah.
Depends on where you work. Okay? Everybody thinks money is in Echo, right? Probably that's where you think it's at. I have a friend that worked in Echo at UAB. She's been doing it for 8 years, and she makes like $26 an hour. I'm like, why do you even work there? But anyway, so it's just where you work. But then one of our students just graduated, they ain't even registered yet, got a job in Tennessee making $25 an hour. So it's where you work.
I have one question. Well, kind of being nosy, but not nosy. What made you choose to quit doing
More money. Yes, much more. Yeah. Plus it's easier. It's stress-free job. I can see when I'm done.
See, it'd be hard for me because I would sit there and talk to people and just get frustrated that they wouldn't understand.
That's okay.
Yeah, I know.
All right, so on page 72, it goes over what steps you should take in doing a karate study. At the bottom of the page, all those little bullets there. First of all, your exam should include grayscale. This was week 1, right? Then we moved on to color, week 2. Now we're in spectrum. So y'all have got all the steps down that you should take. The only thing y'all got to do now is start finding the anatomy a little better, being able to stretch it out, and then you'll start doing props, mid, and distal up in that. So y'all have the basics though right now. Just adding some more stuff to it. Okay? Doppler waveform should be attained from 60 degrees or less. And the ICA should be interrogated with Doppler from the bulb all the way as distal as you can see it. Why do they only care about the ICA? Big brain, ECA, whatever. We don't care if it's even included. And a lot of vascular labs don't even scan the ECA. So,
The EC.
yeah, the ECA, they don't even scan them. Because they're so non-important and they got all those branches, who cares if it's even included? So, you're going to see sometimes they don't even scan these. But I teach you how to do it just in case. The final report should discuss the velocity measurements. Why do we care about the velocity measurements? Ding, ding, ding. Certain velocities mean certain percentages of stenosis, right?
I didn't get one of those.
Well, this might be the one to list. Your B-mode images. So you want to say the images that you found when doing just your regular scanning. Was there plaque in the arteries? When you measured them in transverse, how much plaque did you get? Color Doppler findings. Why do you care about the color Doppler findings? 1, if an artery don't fill up all the way, what does it probably have? Plaque. Plaque is stenosis, okay? Also, when you're looking at color, you want a Doppler in the what? What's that area called? You want a Doppler in? Fastest velocity is found. I haven't told you yet. In the middle, it's called the jet. See if I haven't told you yet. So sorry. Yes. The area where it shows up the brightest color, that's called the jet. That's where it's fastest at. So that's where you want to talk. And you want any technical limitations. Like a lot of the older patients can't be still, especially the ones that ain't all there. You go up into an ICU, they don't know what you're doing, they start jerking, so you can't finish the study. I can't finish the study due to patient, or the patient didn't want the study, or if you're scanning these two ladies, torturous vessel, whatever kept you from being able to finish. Comparison of previous study is important. It's always important, no matter if you're doing vascular, abdomen, OB, look at a previous study that they've had. If 2 months ago they found 50% stenosis in the ICA, we should see, if they've not been on any sort of aspirin, they've not had an endorectomy, anything done, then we should see even more plaque in that vessel. So it's important to know. Just like abdomen. Last week they found a 2 centimeter cyst on the right kidney. Well, this week we better find it too. Okay? So it's important to look back
Okay,
at
wait,
the
so
study.
the aspirin dampens the blood to make it be because of that.
That's what a blood clot is, it's sticking together. Same thing, you can get a blood clot in the artery too. A lot of people don't realize that, but you can. But plaque is the same thing. It's just like, it's a form of blood, and so it's calcium and it just sticks together. So aspirin helps thin everything out. And then on the final report, you should tell the degree of stenosis, if there is any, your final impression. You know, it should include the transverse, true limit versus residual, all right? Then it should include the velocity measurements, and everything that you've done throughout that study should be on your final report. And y'all will start doing text sheets before long. I can't make start doing them yet. Y'all did them abdomen yet? No, little text sheets? Yeah. We'll get to that point, and it just helps you to know how to fill them out. But is every site will have a different text sheet? Yeah. But anyway, it just kind of gives you an idea. And then 2 more down, it says every test center should have systems in place for quality assurance and validation of their criteria. Just like I mentioned in January 2017, if you're not registered in vascular, you're not touching a vascular scanner. So we're going to, yeah, get that. And then velocity measurements for the ICA should be obtained from the point of maximum stenosis, which is called the PSV, peak systolic velocity. All right, turn on to page 74. On number 2, we mentioned last week, when does blood flow, what velocity or what percent of stenosis does it have to reach to become turbulent blood flow? 60%. So everywhere you see in this book, mark it out and put 60%. So number 2, turbulent chaotic blood flow is almost always present immediately distal to a 60% or greater stenosis. This can appear as spectral broadening in a Doppler waveform. So turbulent blood flow is always, the post-stenotic turbulence is what it's talking about, is seen after a 60% or greater stenosis. It can look a lot of different ways, but spectral broadening is one of the biggest things about it. And I've almost got spectral broadening in my image right here. See, this is called your spectral window. See how it's filled in here? This is spectral broadening. Is there anything wrong with this artery? No. It's my gain is too high. I need to turn down my Doppler gain. But if I turn this in, would I get my tail chewed out? Yes, I would. Because if there's no stenosis, they don't want to see, they want this right here to be open. Okay? So watch your gain and don't have your Doppler gain turned up too high. And then number 3, caliper determine estimates of percent stenosis from V mode. Image works best if the stenosis is less than 6%, and then velocity works best if it's more than 60. So remember how we said if you measure it in transverse, if it's less than 60%, it's more accurate. But if it's more than 60%, velocity measurements become more accurate. That's what that's talking about there. And here's some examples of how things have to correlate together. If a stenosis measures 60% or greater in V mode, that means in your transverse, true versus residual, okay? So it measured 60% there, but there's no velocity acceleration, then the stenosis is less than 60%. So that's the example that we've been talking about. In transverse, it measured more than 60, but there was no velocity increase, so it couldn't have been more than 60. And then V is the opposite. if the stenosis measures or appears less than 50% by your caliper, but velocity acceleration when post-synodic turbulence is seen, then it's greater than 60%. Okay? So now in transverse it measured less than 60, but then velocities were increased, so you know it has to be more than 60. So those are just two ways that they didn't match, but you knew what to do because of the way the velocities work. Do y'all understand that? Okay. Going on over to page 75.
On the register, they're gonna say 60%.
Yeah. Yeah, this book is blah, blah. I don't really like this book, but the book we use next quarter follows your registry to a T. Like if you went to the registry seminar, that's the book he uses. So that's why I love it so much. Anyways, it's right in there. Alright, so on the top of 75, carotid criteria is meaningless. So these are three things that you need to see proving that this patient has plaque. Three is meaning to me though. Can you see the plaque within the artery? Alright, you can't always see plaque though, can you? If it's anechoic, you can't see it, right? So you would need to use what to see that plaque? Color. And what would the color do? It wouldn't fill in because it's got plaque there. Velocity acceleration should be seen over the plaque. So if it's more than 60%, that's when they start worrying about it, you're going to see the velocity. And then post-synodic turbulence should also be seen. But what's something else we talked about that should be seen before a stenosis? Dampened flow. The dampened flow, remember, should be seen proximal to, increased velocity should be seen within it, and post-synodic turbulence distal. So add that in, dampened flow should be seen proximal. There's really good examples on those three pictures right below that. If you look at the first picture, this is pre-stenosis, so what type of flow? Dampened. Remember, dampened doesn't mean that the waveform changes, it just has a lower velocity. So this is what, about 40, 42 is the peak systolic velocity, so that's dampened flow. Does the waveform look normal? Yes. Then you move on to inside the stenosis. Alright, now we are at a velocity of what, gosh, 350 probably? That's a pretty high velocity. You can see how they're Doppling in the yellow. You'll see that? The yellow and green? That's the jet. That's why these colors are so important when you're Doppling, okay? Then the next picture is post-synodic turbulence. So they're past the stenosis. You see how the waveform's up and below the baseline. You got the spectral broadening. That's post-synodic turbulence. So those three steps are what a doctor is going to want to see. Dampened flow, increased velocity, and then post-synodic turbulence. Okay, you can turn on over to page 76. 76 goes over the difficult diagnosis, like if it's more than 95%, that's almost completely blocked. These are what we need to be able to diagnose. You remember what it's called if it's more than 95%? Trickle flow. So you're going to have to do a lot of adjustments to even see this flow. The first thing is bring your scale down as low as it'll go. So it'll go down to 10, bring it on down, okay? If you still can't see it, then you go to power Doppler. So bring your scale down, crank your color gain up until it starts speckling everywhere, then turn it back down. You can bring your color scale down. All these adjustments need to be made. If none of that works, your last step is power Doppler. If you still don't see anything, then yes, it's okay to say that you think. Never say it is. And I think, even though the doctors are going to go by what you say, I think it's an occlusion or whatever, however you want to word it. And they're more than likely going to send them for an MRI or CT before going on 100% of what we say anyway. So it says, in some very high-grade stenosis, velocity values may not be useful. Because once it gets over 95%, you don't have those increased velocities anymore. You have that little bitty velocity. You can't depend on that anymore. And just like the little diagram I gave you, what does it say for 95%? Oh, here it is. Look, 99%. it says extremely low. Then the first one has got 80 to 99%. You might find velocities at 615. I'm not 100% agree with that. But now at 99%, it's saying extremely low. So that'd be that trickle flow. And then 100%, you don't have the peaks of salt because you have no flow. Alright? So, it says velocities may be elevated, but may be less than the range used. Often a trickle flow situation can occur due to high resistance of the small residual length. So the vessel's almost completely occluded. We talked about what happens. Resistance goes up, and normally velocities will go up also because pressure and flow go down. But in this case, velocities actually go the other direction, and they go down also. But your resistance is still up. Okay. Right underneath that picture, it says very low velocity may occur in a near total occlusion. In this trickle flow condition, a low PRF, what does PRF stand for? What is a PRF? It's a scale, or a color scale must be used to detect flow. Power Doppler may also be useful. Just remember that. I said a minute ago that even if we call an occlusion, they're going to send them for a CT or an MRI. Yes. But here's the tricker. Even if CT and MRI cause an occlusion, guess where they're sending them? To us. So don't think they're better than us, because they're not. They just have to use 2 tests before calling a conclusion, because it is such an important diagnosis. So we're just as important as they are. Now, going into an ICA occlusion, which is what we talked about a minute ago, it says the ability of imaging to accurately diagnose an ICA occlusion is improved by using color Doppler and power Doppler. Going down about 3 sentences, technologists and physicians should err on the side of caution if not absolutely sure of an occlusion, and recommend an angiogram, which is your CT, MRI, or CTA. Okay, so an angiogram is where they go and inject dye in the artery. The artery doesn't fill up with the dye, they have an occlusion. That's what that is. So ways to help you find the ICA occlusion: determine that there is no flow in the ICA by sampling multiple sites. Don't just say, well, the mid's occluded, so the props and distal must also be occluded. No. Okay? Use color Doppler and power Doppler at normal. Start at your normal PRF, but then go down to low. If you can see thrombus with an ICA, well, that's a kicker. That just tells you right there it's occluded. And also, the ICA will become contracted if it has been chronically occluded. You know what chronic means? For a long period of time. So if it's been occluded for a long period of time, your body just starts to contract because it's no longer working. So it's like your body dissolves it. Okay? On the next page, at the top, it says technical problems such as inappropriate color, gain, scale, and steering should also be avoided. And you should also look at it in transverse. Okay, so those are just some ways to help you. In the middle of that page, it goes over pretty much what we done a second ago. It says the presence or absence of diastolic flow in the CCA when the ICA occluded depends on the ECA. Remember talking about that? Remember, if these ECA branches are not working correctly, what happens to the CCA flow? The diastolic flow disappears. And that's what that says. The presence or absence of diastolic flow in the CCA when the ICA is occluded depends on the ECA. So it depends on how well those ECA branches are working. If collateral pathways are well developed, so they're working good, you'll have normal CCA flow. See that? It says low resistance in the ECA, which is what we talked about. That's why you may call the ECA the ICA, because it's become low resistance. But the collaterals are working well, so your CCA flow is normal. Therefore, CCA waveform appearance may be variable between patients with ICA occlusions. Right? Branches are working good, CCA flow looks normal. Branches are not working good, CCA flow loses its diastolic component in this scenario. Right. Turn it on over. CCA stenosis or occlusion. It says, to date, there are no specific criteria for stenosis in the CCA, meaning that little chart I gave you, that's used for the ICA. They haven't made one for the CCA, okay? It does say, though, if the peak systolic velocity doubles over the stenosis and there is post-stenotic turbulence, then this is consistent with a 60% or greater stenosis. Same thing. CCA, let's say the mid-CCA got 60% or greater, that means the proximal CCA should have dampened flow. Within the stenosis should have increased velocity, and then post-stenotic turbulence should be seen distal. Same characteristics, okay? They just don't have a chart made saying, well, at 70% velocity should be 300 or whatever. They're just saying if it does double, if it doubles within the stenosis, then there's, and it has some post-stenotic turbulence, then we're saying it has 60% or greater stenosis. All right, occasionally, the CCA will occlude. All right, it is important that the stenographer establish whether there is flow in the ICA. Often the ECA will become reversed and will be reversed and fed by an anastomosis between the ECA and the vertebral artery. So see, he just confuses the heck out of you by the way he says it. This results in retrograde flow, which will supply the ICA. So what happens when the CCA is occluded? ECA becomes retrograde to feed I, branches feed the base, and vertebral, like it said here, and basalars become retrograde to feed the E. Right? It's a little easier way than he said it. And then ECA stenosis. There are no criteria for ECA. But again, if you have the post-stenotic turbulence and the velocity increase and you think 60% or greater, ECA occlusions are rare, and when it does occur, it's reconstituted by its branches. Just like I said a minute ago, if ECA is occluded, whatever, branches will feed the face, and everything's good to go. So, does everybody clearly understand what takes place? Will you be tested on this next week? Yes. Yeah. Okay. Carotid artery stent. We talked about this last week. There's a beautiful image of a stent. If they have a stent in any artery in their body, you're going to see it because it's going to look just like that. Bright white walls. It's called a double-walled appearance because it's on both sides of the wall. Because what does the stent do? It goes in, opens up, pushes plastic against the wall. You're going to see them, okay? So that's one way for a patient that has even a 99% stenosis. They can have a stent put in. It says carotid stenting has gained acceptance as an alternative for an endarterectomy for people that are high-risk patients. Not everybody can have an endarterectomy. It's easier to just go in. I don't really know how they do it. I've not seen one. But it's some sort of laser. They go in and just stent it. Endarterectomy, they have to actually cut the neck open, been on many of those, and they clean the artery out. Those are awesome, if you like surgery. All right, and post-op for a stent, when the patient has a stent, you expect to see higher velocities. Okay, so, you know, we know by looking at this chart that a velocity of 170 normally would mean like a 60% stenosis, but if they have a stent, that's why their velocities are higher. Can stents become occluded? Yes, they can. You have to look at them. Okay, that's it on that. You can turn over to page 80. At the very top of page 80. Patients with significant bilateral carotid stenosis or occlusion will have increased flow on the side with the lesser stenosis. So if my right side has 60% and my left side has 70%, I should find more flow going through my right side, the lower side, which makes sense anyway. What do you know about that? Okay. Now, 81, we're almost done with this chapter. Thank you, Jesus. It goes over all the different types of plaque, which we've already discussed. I gave you a handout on them. At the bottom, anechoic, echogenic, hyperechoic, hypoechoic. We talked about all those already. Flipping on over. It says, the very first paragraph there, while some investigators have shown that heterogeneous, which is mixed plaque, it has been more correlated with causing symptoms. Hypoechoic plaques are risk factors for CVA and asymptomatic. So hypoechoic plaques are more associated with symptoms. And and I really like the way he says that. Because if you look at if you look on 85, the very last sentence on 85, it says hypoechoic plaques are more likely to be associated with symptoms. That's what I want you to know. Heterogeneous is more dangerous, it's more of a high risk, but hypoechoic is more likely to cause symptoms. Turn on to page 83. We talked about homogeneous and heterogeneous last week. There's two other words that can be used. Smooth can be used for homogeneous. So you can call it smooth plaque, you can call it homogeneous plaque. Same thing. So it says the surface of the plaque appears continuous and has no irregularities and is uniformly echogenic. So if you look at the first picture, there's smooth plaque. You see how it's just pretty much one even color there. Does it have really any jaggedy edges going on? That's smooth plaque or homogeneous. And then the next one is irregular and heterogeneous. You can use those together. A regular plaque is like the second little image besides smooth plaque. You can see how the edges are more jaggedy. And it's really not too heterogeneous because it doesn't have a lot of mixed echo patterns going. They don't show a lot of good heterogeneous. Oh, they do on the next page. I'm like, where's the good one at? Page 84 shows a good heterogeneous. Y'all see those two pictures? It's bright, it's dark, it's jaggedy. It's definitely not smooth, so what type of plaque is that? Irregular or heterogeneous. Okay? You see the difference in smooth plaque and irregular plaque? Good. Alright, plaque can also bleed within it, and it's called an intraplaque hemorrhage. And it results from a rupture of a small artery within either the artery or the plaque. Okay, so if the plaque is around the smaller artery, it can actually rupture within it, and it causes bleeding inside the plaque. This phenomenon may cause the plaque to increase in size faster than it would because it's filling up with blood, so it's getting bigger. And the ultrasound appearance has like an eggshell appearance is what they call it. And there's a picture of intraplaque hemorrhage. So it's a bleed within the plaque. So that can also happen. Calcified plaque is the last one. Calcium deposits within the plaque may either prevent ultrasound from passing through the plaque or prevent the echoes from returning. They result in acoustic shadow deep to the plaque. If the calcified plaque is located on the near wall, then the shadow, everything below it cannot be seen. If it's on the far wall, then of course you can Doppler on top of it. And there's some examples on the last page. On the top of 85, the first picture is plaque on the top wall, the near wall. See how everything below is shadowed out? So you can't Doppler, you can't put, they've got color on there, but it's not filling up, everything's shadowing out. The second picture is plaque on the bottom wall. You can see how it's shadowing past the plaque, but they can Doppler on top of that plaque. So you can Doppler around calcified plaque depending on where it's at. And then, of course, the last thing we said, hypoechoic plaques. I cannot speak. Hypoechoic plaques are more likely to be associated with symptoms. And that is everything in that chapter. That was an easy one. Easy one. Yeah. I kept listening. I know. It kept telling about what studies. Yeah. Yeah. I don't tell you anything you don't need to know. You don't need to know. Get out of the place. Which one?
alone.
Yeah, just those. Yeah, you don't have to know the N or anything past that. Okay, just know the percentage and the P. Nothing else past that matters.
What are the two plaques that carry most risk? Because I know like the
Heterogeneous and calcified. Those are the high-risk lesions.
Where does it say that?
It's on that sheet she gave us.
Oh,
You
okay,
said-
okay.
Diabetes.
Only 'cause she showed. Miss Davis, you said the first two,
Yeah, just know the percentage and the P.
the peaks of
Sorry, I didn't know anything else about that. No one cares. All right, I'm gonna make a copy of this.
she said it's going to Did y'all get the ability to accurately diagnose this for
Is it that one?
I mean, that's what I was thinking, but.
Oh, correct.
Okay.
Yeah, it was interesting.
Oh, yeah, right here.
It's hard to like be highlighting and then go back there and highlight again. Yeah, to be honest. And then listen to what she's saying outside of that. Yeah.
Okay, and it's gonna be on 1 and 2 or 1, 2, and 3? 1, 2, and 3. Yeah. Okay, so this is what we're gonna do with our free time. Just kind of see, how y'all are thinking as your scanning goes, this is important as written. I'm just gonna go through all these images, and I want you to write them down, or you can put it in your head and tell me what's wrong with each of these images. And so y'all have to tell me, we're gonna look at it, I want you to think in your mind what you think it is, and I'm gonna tell you what's wrong with it. And see if y'all know what's wrong with the images. If y'all get a better idea what y'all need to be turning in, okay? So, that's what we're gonna do.
Just think it in your head.
Just think in your head, and then I'll tell you what's wrong with it. All right. And hint, there's not always something wrong. Okay? So, first image. Y'all look at it for a minute. Tell me what you think's wrong with it, and then I'll tell you what it is. Showing us a little. Alright, the only thing wrong with this image is it's too dark. I need to turn up my overall gain. Besides that, nothing's wrong with it. How do you know your image is too dark? Thyroid is dark. This muscle right here should not be that dark. That's the sternocleidomastoid muscle or whatever. It should also not be that dark. It's almost as dark as my vessels. Okay, so that's the only thing wrong with it.
You have that last one.
Hint, I don't pay attention to focus, so you can fix it if you want to, but I don't really pay no attention to it. So don't worry about that. Alright, so here's your second image. Again, you should have guessed it's too dark, but also the depth is way too much. Okay, don't need all that depth going on.
What is that?
And they may all stay too dark because they're showing a lot darker on here than they are on here. Okay, so they're probably all going to be too dark, to be honest. So you want this type of depth. See how when you look at that, what's the first thing you see? CCA or whatever, right in your face, right? When you look at this, you don't see it right in your face. So that's why it's important to do that. All right? Now, yes, they're all going to be too dark. So, yeah, like I said. Anything else wrong with this image? You should have said no. Nothing's wrong with it besides it's too dark. Okay? Alright, here's another one. There's the answer, it's not open. This side of the vessel is not open. See? So that's an issue. You want to lengthen it all the way across the screen. Okay. Here's another one. Some of y'all may say depth, and yes, you can probably bring your depth in a little bit, but it's actually an okay image. It's the bulb. Everybody see it right there in the middle? It's wide. So besides it being too dark, yeah, it's actually okay. Because some of the machines won't let you bring your depth in anymore. Y'all have probably seen that when you get to a certain point, that's depth. So it's okay. Maybe a little, I don't know. Here's your I and E. Nothing's wrong with that one. Pretty good. The I is bigger. It's more lateral. E is smaller, more medial. And I don't know, I'm not been scanning myself here, I'm not sure. But you can make a tuning fork out of that. See how they're sitting almost on top of each other? But that might be an instance where it's better to do one and then the other. But anyhow. Okay, what's wrong with that? I purposely done that. I made that one way too dark. Alright, so it's the same image, I just turned my gain down too much. I made it too dark. Okay. Now this was a real tuning fork. Okay, I did make a tuning fork out of it. Do y'all see how big the bulb is on the eye? And how it curves down? And the E is more kind of straight across, and it has a much smaller bulb. That's everybody. Everybody who scans going to have a bigger bulb in their eye. Right? Nothing really wrong with that one. And then, it's the ICA, so it's okay. This is not really the one that I had a bunch of stuff wrong with, but since I had it pulled up. There's my I, E. What's wrong with that one? Someone said it. Depth. I don't need all that underneath there. Now for the ICA, I've got the same depth, I believe, on both of them. Yep, but my ICA is deeper, so it's okay. But my ECA is up here, so why do I have all this going on? I don't need it all, so I need to bring my depth in and make that the center of my image. Alright, here is a CCA picture. Looks pretty good. Box is going the right way. The vessel's filled in. I might have filled in a little bit better. See the top up there, how it's not filled in? But you get to a point to where you just start aliasing, so that's pretty good. It's all opened up across. Alright. Here's this one. I mentioned this one a little bit ago. What was wrong with it? My Doppler gain's too high, so I've got spectral broadening going on. I'm not 100% sure that's parallel either, to be honest. I'm looking from the side over here. I don't think it's parallel. Nope. That's good. Good eyes. Alright. Yeah, what's wrong with this one? Nope, it's a CCA. Gotta look closely to see what's wrong with this one.
Is the line so, the angle?
Someone said degree. Look, it's 70 degrees.
Oh,
You
got it.
I was like, I don't know. That's what's wrong with it. So this one actually looks more parallel, but it's 70 degrees. This one's at 60 degrees, and it's not really parallel. Okay, so I can't go to 70, so what do I need to do? I need to either rock my vessel or use a smaller angle, as long as I don't go smaller than 45. Okay? Pay attention to that number up there. Alright, what's wrong with this one? What's causing it to be below the baseline?
It's angled the wrong way.
It's angled the wrong way. This is still the CCA, so why is my stick and everything going towards the right of the screen? Exactly, that's why it's below the baseline. Because I've got my vessel going one way, well then I got my stick going a whole different way, so it's not parallel, and it's picking up below the baseline.
That's not, I was about to ask, can I ask you a question?
Uh-huh.
about- Okay, the ECA and OSCA, why do you angle those?
They pretty much automatically angle towards the right of the screen. So, and then this is just how whoever started scanning carotid decided that the CCA should go. So that's why. And it's actually easier to make it go that way. If you tried to make it go the other way, it's not so easy. You really have to rock your probe to make it angle upfield towards the right of the screen. It's just the layout of the body.
So there's not like a set artery vein which way it goes?
There is. CCA has to go. I mean, that's the criteria, accreditation rules. CCA has to go towards the left, and E and I have to go towards the right. Yep. Okay, so that's why that one's below, because it's not even going the right way, and we're at 70 degrees and all sorts of stuff. Okay, so here's the E and the I. This is okay. It's okay. The ECA is not filled in all the way at the top. See that? That looks like, it almost looks like some heterogeneous plaque up there. I need to check my artery out. And I've been letting y'all turn these in like this, but what I would like y'all to start doing, see how the ECA is lengthened out all the way? Let's make the ICA lengthen out all the way. And if you can't do it with a tuning fork, then do it with them one at a time. Because if you all was helping it, one of y'all was helping, it was better to do it one at a time than the tuning fork. So, you know, be really working on that and getting it all the way across the screen.
Don't blame me. Tell me about it.
And then this is what we looked at a minute ago. ECA, low resistance, ICA, high resistance. And y'all see the differences in the pattern? Someone in here, I said, remind me in class, because y'all's neck is perfect I and E waveform. Nobody remembers? Don't remember telling? I was telling whoever was scanning that. I don't know, their waveform was like textbook how it's supposed to look, and I don't know. But anyhow, high peak, not high peak. And neither of them's touching the baseline, so you see? Can't always look at that. What?
I don't know if it was when I was scanning or not. You said something about the waveform. But I don't even remember who I was scanning.
It might have been you. Let me, I'm gonna pull you up. You care if I pull you up?
No,
I'm gonna show off your scan if it was you.
I don't know.
Cause it was textbook, whoever it was. Yeah, pretty close, pretty close. This is pretty close. Alright. What's wrong with this image? And I gave you 100. What's wrong with this image? No? You can Doppler any, it's the ECA, she's right, you can Doppler anywhere within it, because I haven't made y'all pick a certain spot
Well,
yet.
it's not listed out.
Ding ding!
Oh, I didn't adjust
The
the
scale needs to be brought down, because the peak's only at what, 70? And her scale's at 160. And I probably didn't catch y'all off on any of that yet, but next week I will. Okay, so bring your scale down. But anyhow, if you bring your scale down, your waveform's going to look bigger. But yes, this is a perfect of what it's supposed to look like. All right, ECA, high peaks, touching baseline. See that? ICA, not sharp peaks, not touching baseline. Okay? Both of them had pretty good bit of diastolic flow though, but ECA sharp, touching. ICA not so sharp, not touching. Okay, so that's the textbook definition, but I can go through every one of y'all's scans, and they're all going to look different. But it's just kind of an idea. Next week, I'm going to turn the volume up on y'all's machines because they sound different. The ICA is more of a shh sound, and the ECA is more pulsatile. I'm not doing that sound. But anyway, it's more pulsatile. No, not doing that. Okay, I'm sorry, I thought it was on my skin. All right, so y'all can point out what's wrong and what's right, so that's good. How much time did we waste? Oh, 10 minutes. Okay. Do we have a break? Yeah, we can take a break. Just come back at 11:30 and we'll have that milk break.
What's on our tab?
Great.
Yeah.
A week from today.
What's the point of that? Like, how are you gonna pass your
So, I'm going to change the grade right now. Oh, it's on there. It's on there for now. Now you got it. Thank you. Ma'am.
Some regular pregnancy before the something.
They did hire a new person.
Okay, so we're going to hold you there.
They used to use a lady named Sparkle, and now they hired a lady named Tanya, and that's who does it.
She's just uniform lady.
Sparkle is, yeah.
Is that her real name?
It is. You come in, we're on break. Yeah, because Amanda's going to do a Vascular review for today. So I'm not here. Honey, where you going?
Well, I owe you $10, remember?
Well, I get it. Where are you going?
You have an idea.
Y'all sound
You know, I don't like this.
You guys be absolutely.
I already told her stuff. I don't care. You know. That's what I tell her. I said, wherever you want.
I don't, one day you said I'm a lazy. And I'm a lazy.
Did he really come by? What time? Because he had to come by and get something for me.
10:20.
10:20. That's God, Darren. 11:20. 11:20 right now.
Oh, about 30 minutes, 40 minutes. So I don't know.
Whatever. He didn't text me all devil. Wait, I don't know.
What do you not want?
Taco Bell.
No Taco Bell. Lemonade's one of 500. What else?
Y'all had Subway yesterday, right? No, you didn't get yesterday.
Oh, you know it's good.
Why?
I don't like Subway anymore. I like when they throw it.
Oh, yeah.
Oh, it's their Subway.
No, I have it from there. They don't make meatballs up there.
Firehouse Stuff has the best meatball stuff. I can go to Firehouse Stuff.
Are you really going to Firehouse? Well, I want Italian food. We're going there.
Fine with me.
Okay, that's what I want.
Oh, like a long one,
No,
half one?
half one with everything but no onions. It's however they make it, but no onions.
time of bread.
So jalapenos all the same.
Well, they don't come with all that on it.
Don't they ask you specifically?
No, that's Subway. Just that one Italian, no onion.
Italian onion. Italian onion.
If it comes with a drink, no, I don't need drinks, I got plenty of drinks here.
That's right.
Chips.
I got chips in the drawer.
Down there you go.
I'm not.
Okay.
Italian onion.
Yeah.
Italian onion. Italian onion. Italian onion. Italian onion.
Good forgetting.
She'll text you.
Don't say that.
Squirrel.
She's still saying it. Crazy thing.
Are you gonna bring it up here and we'll do the leg? Draw on the wall?
Show him off. You come out here. Why didn't you come get me? Come on the door. Where you at now? Darren, you had to get that baseball stuff. That's the whole point of you coming by here. God. What? 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 From who? Why? Whoa, why would you do the first one? Don't even make no sense. No. 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 Why? No.
They're gonna get USA Today.
No.
They got the Back
That
to
is
the
not gonna,
Future.
that can't work.
USA Today coming. Marty McFly.
Oh, that's right. Today's the day, isn't it? It's October 21st, 2015. That's right. I used to love that movie.
No.
Back to the Future, you
Back to
know,
the
how
Future.
their future thing was today. Y'all are too young, probably.
No.
I love Back to the
So what are you
Future.
gonna do?
That's all three.
Me, I did too. I really still love the first one.
Yeah, first. Two was okay.
Yeah.
Three was was it?
Is it the second one they go to today?
Yeah.
Yeah,
the
okay.
second,
I forgot.
You know, I watched that with my little girl last week or two. Well, a couple of weeks ago.
yeah. Which one? The first one?
The first one,
Yeah.
and I was like, you know, I watched it a million times as a kid. It's cuss. It's crazy.
Do they? I don't.
I mean, I guess I never, I mean, I didn't notice it as a kid, and then I'm sitting there, you know, with my kid, and I'm noticing all these.
Somebody posted something, it's like, well, here's what we're supposed to wear tomorrow. Did you see that, where they had like, you know, like, cause they showed like Biff or whatever, you know, trying to dress like the future, you know, and it was like, we don't dress like
Oh,
that, you
because
know.
I'm at
Everybody's
5,
wearing,
7,
that's what everybody's gonna do this Halloween, I think.
That's
Yeah.
No.
I didn't even think about
Get
that.
a life jacket.
How many questions there was.
Okay.
I'm fixing it.
I clicked on mine and I was like,
No, your homework.
I was like,
I've been doing my homework.
No, that was me.
Actually, I was sitting there in the portal when it happened, and like my grade just and I was like, oh my gosh, what happened? I couldn't believe they said son of a.
I don't remember that.
Like a couple, like.
I guess because I watch it on TBS all the time.
Yeah, yeah, but I guess they cut it out.
Yeah, it was on TV, I don't know. I don't remember.
Yeah, it's on TBS.
I think I be spending on Netflix on my cable. I don't know. I be seeing it somewhere. I never watch it.
Yeah, that's good. I think it's on the road.
Yeah, so that's it. Oh, they got 1, 2, and 3, and
Yeah,
it's like 3 or 4 of them.
Yeah, it's like the year.
It was more down.
I don't know what it is.
You seen Goonies though, right?
The Goonies, all the kids that play baseball? Yeah.
No, the kids, they go on an adventure.
So the man have their baseball went over his finger.
You gotta watch the Goonies. Goonies is
I didn't see the Goonies, I know what it is. What those kids?
It's kids.
I love the good.
And they go on an adventure. It's almost like Indiana Jones but with kids.
Yeah. They go like a house or something?
Yeah. Big house.
I don't know
It's a pirate ship.
From House
What'd you say?
if I've ever actually seen it, but I know exactly. Yeah, and they have like the guy with like the corn face.
Yeah.
They give him ice cream.
I know what you're saying, like
That weird old lady.
with baseball over the house and then the big.
Yeah, and the woman also got, Annie, like, what is her name?
I can't think.
She's also in Titanic. She's the mom of Rose on Titanic.
You just,
I mean, I just don't
Well, you know, to ask them, we put on chronic CT and what do you supposed to do with that?
Don't turn on harmonic, it's way too dark.
Okay, so
That's what it is.
If you don't like the way that it's looking, like it's grainy, you can change it gray matte.
okay, if it's grainy, change it.
Yeah.
That, I told you, I knew it was something. I was like, oh my.
like, there's something that I'm not so blurry.
So both yours.
Like, to me, I mean. Today is the day that they had on Back to the Future. They were like, bringing up to the future. It's that day.
I don't even know what that is. Back to the Future, never heard of it. Never watched it. I've never even heard of it. Oh
Oh my gosh.
Look, listen to this. The other night, my mom called, Joe answered the phone, and she said, tell Emily the Halloween zone.
They all have blue eyes.
I said, Michael Myers is I did too. Where have you been?
See, I don't like stuff like that.
I don't either.
I don't like it.
Yeah, I like it.
But I know who it is.
See, I didn't know who Shimon remember what, I didn't know what.
That's a little bag thing.
Oh.
All right, so I'm gonna tell you what you need to know for your test.
Let's go.
Some of what you don't know, not everything. Yeah, you can just give us the answer.
I don't do good on the written Okay, are you gonna have any, like, how is your test set up? Do you have fill in the blanks, true and false, or is it all?
Not in hemo, it's multiple choice, but might there be a diagram pop up? There might be. So, this one, I don't know. Alright, you need to know how color Doppler and spectral Doppler are generated. What part of the machine makes color Doppler, what part makes spectral? Okay, you need to know how to get rid of aliasing. Remember, use a higher scale, decrease your baseline. Use a higher Doppler angle, all those things. Okay, lower frequency probe. So, how do you get rid of aliasing? What are some advantages, or what are some differences between continuous wave Doppler and pulse wave Doppler? What are some advantages of each, but what are some disadvantages of each? That's in chapter 1. Everything I've mentioned so far has been in chapter 1.
Between color and.
No, continuous wave and pulse wave. What are some advantages of each of them, but what are some disadvantages of each of them?
How many sleeves on that?
50. When you're dealing with your CCA, IMCA, and ECA, which one is low resistance, which one is high resistance, okay? And, like, what are the flow patterns? Like, CCA has characteristics of both the E and the I. ECA has a sharp peak, such as the baseline. ICA has a more rounded peak, more diastolic flow, it doesn't touch the baseline. So, that came out in chapter 2. Just know the flow characteristics of the C, I, and E. And those are all in chapter 2. Go over all your stroke symptoms. And you need to know which ones are related to the vertebral valvulars and which ones are C, I, and E. An easy way to know that is if you'll memorize vertebral valvulars because they're shorter. If they don't fall in that category, what do they fall in? C, I, and E. So that's one way to know it, okay? But then know the definition like aphasia. What does that mean? Dysphagia. So go over them, but then know the category of them. Of course, you need to know the branches off the E in order. And the first branch off of the I, you need to know that. Where is the most common site for plaque to form? As far as the aortic arch, know the first, second, and third branch. And the names, different names that one of them has. And then your different types of stroke. TBA, TIA, and REN. Which angle has the lowest frequency shift and which one has the highest? Which angle has the lowest frequency shift and which one has the highest? And that's also back in chapter 1. Go over your plaque, the handout that I gave you. Look over your frequency shift, like what makes a positive shift and what makes a negative. Of course, these 3 things here you need to know. And when is the diameter measurement more reliable? And what percentage of stenosis? And when does velocities become more reliable? When does velocity measurements become more reliable? And when does diameter measurements more reliable? And that's pretty much it. A lot of questions on all that stuff.
And are you gonna be here Thursday and Friday too?
I'll be here Friday.
You want me here Friday?
But you're gonna be here today for tutoring.
But you're gonna be here tomorrow.
I am here tomorrow, but I'm talking close 5.
Before that.
Well done. Wow.
I'm 9. Yeah, they give me a whole afternoon. Wonderful. Yeah, if I get here around 9 in the morning. Alrighty, well, y'all can go.
Like I wasted enough.